Sorry, should I switch screens?
No, you're good.
Okay, great.
I was just wondering if you got the hosting for this.
So I didn't get the hosting thing, but it looks like I am the host still now.
Yes, that's what it looks like to me. Okay.
Yeah. Anyway, so we've just about hit our curve here with the joining. And so today we are doing something dramatic, which is we are not going to have Eileen run into Sheila's time. Sheila's going first. So we will do our Bartlett updates first, and then we have a really interesting case from Jill Crank and one of her students. So just some upcoming conferences information. So today we'll do Bartlett updates and cases. Next Friday, Paul Sachs is coming to give a talk called The Future of HIV Care, and really focusing on what we should be delivering and how and who should be doing it. Then we're really lucky to have Jean Keller coming to talk with us about GYN care for people living with HIV later in May. Then some early intervention service updates from Joyce and others in the clinic, and then some case conference on the 19th, and then cases again we'll plan for the 26th. Some other things that are on the schedule. Todd Brown will be coming to talk with us about the reprieve results. And to anybody who missed last week, he was on very briefly at the beginning of the session, just to make sure everyone was aware that the reprieve study, which was a study through the ACTG looking at the role of statins for prevention of adverse cardiovascular events in people living with HIV, was actually stopped early because it worked well. And so any participants from our clinic who are in that study will get a letter about that. If you have questions about that, can certainly reach out to the study investigators, which includes Todd, and then he'll come and give us more of an update about this and whether statins should be placed in the water supply. And then Gail Birkenblatt has preliminary agreed to come and give us some updates on primary care topics for all of us who are Maryland PCPs. And then I did just want to put here, so this is the link to the YouTube channel. So in the past couple of weeks, we had Dr. Monica Gandhi talking about long-acting therapeutics and thinking about how we might apply that in our clinic. That is on the CFAR channel, which the link is right here. And then also Dr. Judy Levison, who came last week to talk about breastfeeding in women living with HIV. That talk is also available on the website. So now, without further ado, I will stop sharing and turn it over to Sheila.
Hi, everybody. Thank you for having us. Dr. Scully, I hope I can have 15 minutes. Oh, I won't be here on the 5/26. We'll figure out something. Maybe we'll go to June. So, I'm going to start sharing my screen. So Stephanie is really going to be the one that speaks here, because Stephanie really does a great job with helping us to meet these primary care metrics here in Bartlett. So let me share my screen so that she can begin to speak with you about this stuff. And Steph, I will advance them when you're ready, so you'll let me know. Can everybody see my screen? Okay.
Yep, looks great. Thank you, Stephanie.
What we hope we're going to accomplish today is that we're going to look at the March core metric results. Since our core metric for the month of April was wellness visits, which, we can also focus on them in May since it is the end of April. And then we're going to talk a little bit about how we can meet the metric for controlling hypertension, which we are very close to. And then again, just CMA provider communication and anything else that you wanted. And we really appreciate you giving us this half an hour. So I'm going to go to the next slide. Steph, did you want me to do this slide, or are you going to do it?
Sure, you can go over it.
Okay. So here's how things are looking at Bartlett for the March core metrics, which we just continue to improve. So although it's in the red, I just want you to realize that we have made leaps and bounds in meeting these core metrics. And we are just so close in many of them to meeting and exceeding it. So I appreciate all that everyone is doing. I think like I'm meeting with the CMAs this week to get ready to do their annual evaluations and just having a check-in with them. And Jamila came up with another great idea about doing same-day mammograms. So I just think everybody comes up with really good ideas every day on how we can meet these metrics. But here are our March core metric results. So breast cancer screening, the expectation is to have 80.6% people have their breast cancer screening. And last year at this time, we were at 52.94%. But this last month in March of 23, we're at 60.63%. So you see, that's like an 8% increase. So again, I just thank everybody for that. For colorectal screening, last year we were at 60.3%. This year in March, we're at 60.78%. And again, we're getting close. The expectation is to be at 78.4%. So for both of those, breast cancer screening and colorectal screening, Abina started this about a month ago. Not only does she put annual wellness visits in the appointment notes so that the CMAs can see that, but she's also started adding when people are due for colon cancer screening and breast cancer screening. So if you set up your schedule to include when some things are due, you'll see that BCS and CCS is now a part of that. And if anybody needs help in setting up their schedule on how you can look to see what's due, please let me know. For hemoglobin A1C this year, last year at this time, we were at 37.5%. This year, we're at 30.65%, with our target being 18%. So the reason that we were meeting this target, and we will meet it again, is that it includes everybody that is due for a hemoglobin A1C in the calendar year. So that's why it looks like we're not there, but we will get there. So please don't worry about that. For the annual wellness visits for our people that are age 20 to 21, so those are really our ACE folks. The denominator is really small there, like it's either 1 or 2 or 3. So when we miss 1, that's what happens. So just really important with those ACE folks that we are doing that annual wellness visit when it comes up. By all means, if you can't do it during that visit, schedule them for an hour the next time around. And that's with all of our patients. If we understand, if you can't do these annual wellness visits in a half an hour, please schedule the patient for the next time for an hour. And then for wellness visits for the rest of the folks that come here to Bartlett, last year we were at 60%, and this year we're at 54%, and we're trying to get to 80%. So again, we're getting there. The good news is we're making lots of progress. I think when I started here 4 years ago, I think our annual wellness visits were at 10%. So definitely making progress. So I appreciate all that everyone's doing. Any questions on this slide before we move on?
This is Joe. I put it in the chat. Does that capture when we do referrals for colonoscopy or Cologuard or mammogram orders and the patient just doesn't do them?
So in order to meet the metric, the patient has to actually do them. It's counted in the metric when they've completed.
Right, and that was my understanding too. And the point here is, like, no matter how many schedules we put it on or how many things we do, if our patients don't follow through, I don't know what else we could do. Except perhaps, Stephanie, they live with you until they get them done.
So Dr. Francesco, that is like something again that I'm going to meet with the CMAs about this on Tuesday. And again, I don't think that the workflow is really being followed for, like, sometimes the mammograms, the same day mammograms, like, say to the patient upon rooming, oh, I see you have an order for a mammogram, or I see you're due for a mammogram, and then let the provider know, this patient needs an order for a mammogram, and say to the patient, can you go today? I'll get you over there today.
Till what time? Because for those of afternoon clinics, sometimes we're told, unfortunately, it's too late.
Well, let me look.
I
I
believe the
don't,
cutoff, last time I heard the cutoff was either 2 PM or 3 PM, but we can verify.
Right, which means for afternoon clinic people, it's essentially impossible to get same-day mammograms.
so I didn't know there was a cutoff time, Stephanie, did you?
I thought that it was 1 o'clock, actually.
So let us clarify that. I'm looking at my same day mammogram workflow. And I'm gonna call them. There's a dedicated number here and I'm going to ask them what the cutoff is. So we will get back to you on that and let you know that.
And Sheila, just one quick point in terms of like targeting how we complete our metrics, like from Joko's perspective, like how, like, where should we be hammering on getting these done? Is it providers not ordering them, or is it the barriers to getting them done? And I think like for something like colonoscopy, for which I know like lots of people are ordered for it who don't get it. And like, you know, a couple of my patients have had trouble with transportation or the order for the Go Lightly or being reached by the endo clinic, you know, like there's many, many things, but
Yeah.
I think we can talk about it till we're blue in the face. But if they're ordered but not done, then we could make an argument for resources to support the space between the order and the accomplishment, right?
Yeah, that I agree, totally agree with you.
Yeah.
And it's just something that we are continuing to work on. Like the orders are in there, but the patient doesn't understand the instructions. The patient doesn't have somebody to pick them up or, you know, escort them when they go to leave the colonoscopy. So then they can't get it done. So there are many layers of
Yeah.
getting this successfully accomplished. And those are the things that we're going to continue to work on. We're improving, but we can always get better.
And there's also an MD-PCP medical directors meeting. And the last meeting we had, we talked about this, about Cologuard, about colonoscopy, because also, you know, for the Cologuard, for some patients, it's very confusing. They're not quite
Mhm.
sure how to do it. They send it in and then it says it's not valid. And so with respect to colonoscopy, one of the things that the MD-PCP medical director team will be doing is actually meeting with GI and talking about,
That's great.
because you know, the communication has not been great, I don't think, based on the experience of my patients, for, you know, knowing how to do the prep once they get it and, you know, all of these kinds of things. So that's one thing, is like directly working with GI for them to improve their processes. The other thing that we talked about at our last quality meeting was having more data on really what your question was, Eileen, like, is the problem not ordering? There's no order. Is the problem more the sort of follow through? I suspect it's more the follow through, but we'll be able to see, you know, who had a referral. And then again, you know, working with GI to improve their process. But then once we have the person, you know, here, the MD-PCP, whatever support we have locally, there's more that could be done by that person, right, to help support that patient complete. So those are some of the things that we're working on in that category.
I really don't think it's the order. I think the orders are there. It's the like Stephanie Thornton has said it so well. It's like a relay race and you're passing the baton, right? And we just need to get better about our baton passing.
So can I make a comment about mammograms? Because I, of course, ask about it every visit, and it's often in the order's often in the chart. I think the primary care providers do a wonderful job of ordering it. But sometimes the client doesn't know it's there. So it's like, oh, I was supposed to do that. I think we talk about so many things, they forget some stuff. And if they don't mention it when they exit, so I try to put a little note in for the registrars at the end and say, can you help her or give her the number to make a mammogram appointment? So I think there's sometimes a just disconnect on what the patient thinks she's supposed to be doing in order for follow through. So I think we can improve there as well.
Yeah, and I'm not only talking to the CMAs, but I'm going to meet with Abby and her team again about, you know, when patients come to check out and they have these orders, please help them make these appointments. And
And-
then, you know, I also agree that in some ways, like the nurses could be helpful that are assigned to these patients that have these colonoscopies to help them to talk with them through, you know, this is what you need to do. The patients just need a lot more support and understanding. And sometimes just like I've done this, I did this with a Dr. Jones patient. I just was like, okay, I have a minute. I'm going to wheel you over there. Because if they do get over there, they are so quick over there with getting these mammograms done. You literally, you check in and you're in the back getting your mammogram done within 5-10 minutes.
And
But
I
just-
do want to mention one more thing. So this is something kind of new with working on it with the nurses. Nurses are getting reports every month with opportunities for patients. So I've had a few patients that I've called who have missed their colonoscopy appointments. And I've had assisted them with rescheduling and kind of assess their barriers. If patients don't have somebody to come with them to the appointment, we have navigators that can go if they know in advance. So I guess just, we're working on it, but having nurses look at those reports and working on those patients who are overdue. And if you have a patient that you see and you know that they've had this colonoscopy scheduled for some time or ordered rather versus scheduled, please send your nurse a message and ask them to reach out and figure out what we can do to help that patient get that screening done.
And I'll just say, because you guys are doing such amazing work, just to add to these things, I think like if there was an easier way to figure out where to call, like for a lot of these appointments, because sometimes I just do it with the patient in the visit because it's so important. And I know that there's only one PSC and like, they're not going to have the bandwidth. But half the time for me, even, it's hard to figure out who to call. And I called someone on Monday for a patient and they told me they didn't have her scheduled. And I was like, I can see the order in front of me. And then she was like, oh yeah, I found it. But like, if I had been the patient and hadn't been able to say, I can see the order, she would have said, we don't have anything for you. And I just think that is such a huge barrier. And so if there was some like wiki where it was updated regularly of the numbers to call for these places, or if Epic could build in like a better way to figure out how to schedule these things, that would be such a huge advantage.
All right, I'll just real quickly, because we're kind of getting and cutting into you guys' time, go over just some best practice workflows for the well visits. Well visits was our metric for the month. Like Sheila said, we'll probably push it again for next month. You all know that if time is available, we can flip visits. If you have those days where there's cancellations or looking ahead of schedule. So there is a health maintenance column that you can add. There's a well visit due column that can be added in schedule management, and you can look ahead of time and see which patients you have overdue or coming up on our wellness visit. And if you can do it the same day, great. If not, please send them to check out with a note to schedule their appointment coming up for a 60-minute visit so that can be done. Additionally, if there is a patient that you recognize that you can take care of, just like, the CMA should be looking ahead of time as well, but they should be asking if you're able to do it. And if you can, they can get the HRAs done during triage. If you notice that there's a patient who is very tech savvy, utilizes my chart, HRAs can also be sent in advance to patients to complete before their visit. Sheila, you can go to the next slide. Oh, one more thing I wanted to mention too with the wellness visits. So patients with priority partners, patients with EHP, US FHP, and the JH Med Advantage plan, they can have their wellness visits due anytime during a calendar year. It doesn't have to be a specific date from their last wellness visit. It can be done anytime this year. And so for our ACE patients, this will be 18 to 21. They also will be due for wellness visits, and same thing applies. The visits can be flipped from follow-up or acute to just address preventative care needs. A lot of times these preventative care needs are being discussed anyway, so just properly code for them so we can get credit for that. Okay, Sheila. And then for our controlling hypertension metric, we are really, really close. And last year we were actually meeting it at some point. For our we already have workflows in place for patients who blood pressures are greater than 140/90. If their reported blood pressure is greater than 140/90, they'll fall into our registry for uncontrolled hypertension. During triage, they're supposed to be having an arm run blood pressure to be verified. If that's not being done, please talk to your medical assistant so that can get done. If that blood pressure still comes back greater than 140/90, that patient must have a follow-up visit within 4 weeks. This can be a provider visit. It can be a telemedicine visit if they have a blood pressure cuff at home. It could be an RN visit, which will be great, so we can provide them with some education. If necessary, PharmD visit. Additionally, there is a blood pressure flow sheet for our patients who know how to utilize MyChart well. That can be ordered. It can be added into their chart. If the patient has a blood pressure cuff at home, they can be checking their blood pressures every day and updating it into their flow sheet, and that would populate in their chart. If those blood pressures that are being recorded are below 140/90, then that will be considered meeting our metric and controlling that patient's hypertension. And if you have any questions about that, please see me and I can walk you through any process for the tool sheet, because it's a little tricky for some patients.
I just have a quick question, Stephanie. If I have a patient whose blood pressure is over 140/90, should I be referring them to somebody for a follow-up 4 weeks? Because
yes, they should be staying
Okay.
within 4 weeks, Kristen. We need to
do you
see them again and record their blood pressure. So it could be their nurse. If you feel like
Okay.
you need to see their provider again, they can also do that. And
Okay.
patient recorded blood pressures, as I said, do count towards a metric. So if they have a blood pressure cuff at home and they're checking it, if they tell you like, oh, my blood pressure is always better at home, if they're checking it at home and it's lower than that number, they can be adding their blood pressure into Epic. But even if they don't, MyChart, even if they don't know how to do that, they can call their nurse and we can also add it in as a patient reported vital sign and it would count.
So to make things easy for a specialist, should we just refer for a nursing follow-up within a month?
You can do that. Send a secure chat.
Or to check in with your nurse.
Mm-hmm.
Yeah. Okay. Thank you.
You're welcome. And if you have patients who need blood pressure cuffs, we have them here, but a lot of the insurance companies will pay for them under DME. So we can try that route first. So if there's any insurance issues, we have some here to supply to patients if needed. Next slide, Sheila. Next slide, Sheila. Sheila. I don't know what happened.
Hi, hold on a minute. I gotta get to my slides. Getting to the last slide. Give me a second. My computer has kind of stopped doing what it needs to do. Hold on.
So basically the next slide would be,
I got it. There it is.
We want to work towards implementing a primary care pre-visit planner. So just a little quick huddle touch base. If you can get to clinic 5 minutes before to talk to the CMAs. We are looking ahead of time, as Sheila mentioned earlier. We have Abina, and initially it was Sheila doing it, but now Abina is doing it, looking ahead at opportunities, and they're being notated and the appointment notes every day. And we also have this workflow where we have a CMA tool sheet. So it's this pink sheet. And when CMAs are doing their triage, they're looking for opportunities and they're checking them off. And this is just a visual tool. Even though you guys can see it in your care gaps, it's just a visual tool just to know, okay, this patient still has this care gap that needs to be addressed. So next slide, Sheila. Basically, what we want to do is a pre-visit touch base. So this should be with your MA. If you need your nurse, you can get your nurse to come as well. If you notice ahead of time that you have any patients, like that patient who you've ordered a mammogram for years and they haven't gotten it done, and they need, some extra support, or maybe they want to go for that same day mammogram, we can talk about that prior to and kind of prepare for it if necessary. So that could be calling over ahead of time if the patient's willing to get the mammogram done, and we can get transportation set up, things like that. So just a pre-visit huddle every clinic session, if we can, 5 minutes before, to talk about any patient issues. And it doesn't have to only be limited to the care gaps, any other things or support that the patient may need. That's pretty much it. It's a good time too to talk about if you have time to flip visits for a wellness screening, so the MAs can know ahead of time to open up the express lane and get the HRA questions done during their triage.
So does anybody have any questions? Any ideas? I mean, we're open to.
So I guess one thing I'll say is I think this model is like super important, but I think I often feel But I think probably even talking about it in ways that we can use the same type of approach for other things that are not on this list. I feel like the annual wellness stuff ends up feeling like a bit of a flog. When you also need someone to like go to see endocrine or vascular or, like there's other things, but if there's ways that we can develop this sort of team-based approach so that we can support people to do all the things they need to do, which includes both the metrics and there's a reason for the metrics, right? They're shown to be beneficial, right?
Yeah, they're
Like we're-
preventative, yeah.
Right, they're important, but I mean, I had someone who was discharged from a 3-month hospitalization against medical advice to my clinic, for which the annual wellness visit stuff was done, and I was like, no, like, no.
No, right, we
Like,
get
he
that.
just came downstairs with all of his belongings in a bag. Like, we're not doing annual wellness visit today. But still, the model is really important.
And we've always said that, like, I know that the patients, you haven't seen them for ages and they come in and there's 50 other things that you need to address. We get that. Like, yes, you're not going to do an annual wellness visit that day when you have all these other acute things going on with the patient.
But also, even just that this model, which exists to help us reach these metrics, could also help us like get the other things that he needed on that day, right? And the integrated team care approach, which this is like setting up as a actual system, like could really benefit a lot of different things.
Right. Okay. Well,
Well-
again, thank you as always for letting us join and well,
Thank you.
Eileen, I'll be in touch about it next time.
Yes,
And
your
yeah,
next
yeah,
date. Stephanie, thank you so much for joining us. It's
Yeah,
great to
thanks.
have you here, and thank you for all the work you do for our
Yeah.
patients. And of course, we're always happy to have you.
Yeah, thanks so much, everybody. Have a great weekend.
Okay, so now we'll switch over